Well, good morning everyone and welcome to Birmingham. My name's Martin English, and the first slide here shows Dr. Sidney Farber is one of the fathers of paediatric oncology. Is a hematologist, or was a hematologist from America, and he is one of the people who began first treating children with cancer when he published in 1948 the first account of successful induction of remission for children with leukemia. And on the right hand side of the slide you can see how you actually do a bone marrow biopsy. I won't go into too much detail of this for everybody, but it's obviously that's how we can get those things there. Now, I've recently been reliving my youth because I was given a boxed copy of the Monty Python films for Christmas, and so I was introducing my children to Monty Python and the Holy Grail. And I'd forgotten the introduction to that, which has a practical joke, which it begins with the opening reel of Bug Bunkhouse in Dentist on the Job from the 1960s. And Faith is probably now feeling a bit like I was when my girlfriend looked at me and said, "What have you brought me to see here then in 1980? But fear not, it is relevant. Faith asked me to talk about what was different with brain tumours, and I think you can actually answer that question in two ways. The first thing is obviously differences between brain tumours and sort of other malignant conditions that we treat in childhood. But the second thing is what changes and new things are happening in treatment. So Faith heard me give a similar talk in 40 minutes to a group of health professionals where I was asked to actually give a complete overview of all brain tumours in children. And so she said, could you do the same thing to a mixed group in 20 minutes? So that's going to be a little difficult to do that, but I think if I answer the first question, what's different about brain tumours and other malignant disease in children? One of the first successful treatments for brain tumours was in 1879 in Glasgow, where I come from, where the first brain tumour was successfully removed surgically. It was 70 years later that Dr. Farber, whom we saw before, published the first report of the successful use of chemotherapy for leukemia. But yet, one would say there has never been a situation since Dr. Farber's report that the outcomes for brain tumours have been better than leukemia for children, certainly not within 10 years once other treatments came in. And part of the reason can be alluded to with the picture of the bone marrow biopsy needle. It's relatively easy to get blood. It's relatively easy to get bone marrow. I can do it. It's got to be easy. But you've actually got to do quite a lot of training and be very technically skilled to be a neurosurgeon and remove brain tumours. And it's not until the last couple of decades that we've had access to CT scans and MR scans that have really allowed us to localise what is happening inside the head in a non-invasive manner. So, and then the final thing is the fact that there are a whole lot of different kinds of brain tumour, and as far as leukemia is concerned, there is one big diagnosis which is common acute lymphoblastic leukemia, then a lot of others which are less common, but that means that in terms of numbers you can answer questions more quickly. But we are catching up. I'm a neuro-oncologist and we are catching up to make the results good for everything. So to comprehensively do everything in 20 minutes would clearly mean I had to speak faster than I'm doing already, and so I'm not going to try and do it. But actually, I have in the packs for those who arrived after me, there should be a handout that says what's different about brain tumours. And perhaps if I give this to Heather, if anyone doesn't have one, if anyone managed to arrive before me, then if you want to have that, it's got the, I'm not sure if the talk's going to be much good, but it at least has the URL, so you don't have to write all these down. But the best comprehensive review from the parent's point of view of, as an introductory primer for brain tumours, I think is from the Brain Tumour Foundation of Canada. It's published last year and it's available electronically through that link there. So what I'd like to do is to focus what we do in this talk and to focus it down to a number of things. And to do that, I'm going to use something called the Children and Young People's Health Outcomes Forum. Last year, the government tasked a number of organisations and individuals to come up with some ways to improve the health outcomes for all children and young people in the UK, not just children with cancer, but everybody across the board. And one of the work streams was looking at health. It was led by Dr. Ian Lewis, a paediatric oncologist originally from Leeds, but who's now the medical director at Alder Hey Children's Hospital. And they came up with 5 areas that you need to look at: prevention, identification of illness, assessment of that illness, treatment of that illness, and then long-term care. And they framed a number of questions for each of these things. And so what I've done is I've taken some of these questions and then applied them to brain tumours today and for the future, and I'll use that to give some introductions into a few areas, but obviously I can't be comprehensive in 20 minutes. So first of all, in terms of prevention, how do I stay healthy and how do I stay out of hospital? Well, brain tumours are fortunately very rare in children. 1 in 600 children will develop cancer, and 1 in 4 to 1 in 5 of those cancers, and I'm using cancer in its broadest possible definition here, will be tumours of the central nervous system, which means that about 400 UK children, depending on when you say you move from being a child to a young person, 300 to 400 a year in the UK are diagnosed with brain tumours. So it's a problem that's similar in size to meningitis or diabetes in childhood. That's the similar numbers to what people are being diagnosed with. But it's not a large problem in terms of the 60 plus million in the UK who are there, where health problems such as autism or asthma or lots of other things, accidents, need for immunisations are also there. So we need to inform people, tell them about it. But for those 300 to 400 cases, we can't really do anything to prevent them from happening. It's not like we can introduce stopping smoking to prevent lung cancer. There isn't a single cause that we can target. But what we can do is look at delayed diagnosis, and we will come to that. Also, how do we concentrate? What do we pick on? Well, the list of diagnoses here, I said there's a lot of different kinds of tumour in childhood. 76% of the brain tumours are listed there. High-grade glioma, brainstem glioma, medulloblastoma, low-grade glioma, and ependymoma, and then there's a few other diagnoses which are there. 14% of those tumours actually account for 44% of the mortality in childhood tumours, which is high-grade glioma and brainstem glioma. There are other tumours, particularly medulloblastoma and ependymoma, where 10 years ago, 20 years ago, the mortality would have been far higher, but advances in treatment have brought things down. But this helps us to see where some of the areas that we need to concentrate on are. But again, when you actually look at the actual annual numbers of cases in the UK, you can see it's going to be very difficult to run clinical trials to do that. So, moving on then, how do I know if my child is ill? An identification. Can you help me? How quickly am I in the right place? Do you have the right skills and facilities to help me? Well, I'm going to focus on 2 things here. The first of them is the HeadSmart Campaign. Am I about 10 minutes in? Yeah. That's it. Yeah. So the HeadSmart Campaign has been running for a few years and looks about educating doctors and families about the symptoms of brain tumour in childhood so that children can be diagnosed earlier, so that we can try to reduce the problems that people have by the time of their diagnosis. I'm going to give a brief example here. This is a composite of cases. This is not an individual patient. Tom's not been well from Christmas. He's had poor school performance, vomiting at school, back and forward to the GP. The GP makes a referral to paediatrics, but Tom's up and down. And on the day he gets seen in hospital, he's actually having a really good day, and he gets discharged because he's having a really good day and we think it's getting better. And then it gets worse again, and then we get to the summer holidays and he gets much worse, and then Tom gets admitted as an emergency to hospital with that very large lump, which is here, and something called hydrocephalus, water on the brain, which is causing a lot of problems. And had that been identified a few months earlier, it would have solved a lot of problems for Tom that he was left with. So As far as the Brain Pathways project is concerned, of which HeadSmart is part, there has been guidance issued to paediatricians in the UK about how to diagnose brain tumours, but it needs to be understood that the symptoms of brain tumours are very non-specific initially, and the vast majority of children who get symptoms which could be due to a brain tumour will actually turn out not to have them, which makes things very hard for GPs. And the aims of the Pathways project was to increase awareness generally about it. And I'm afraid I failed miserably in that I'd intended to bring down some symptom cards to hand round to everybody to show you, and I managed to forget them and leave them in my office and not bring them with me. But there are some symptom cards that have been produced that can be, ultimately what we want to do is to put them into the red books when children are born, so that people know at different ages what are symptoms that should make you go to the GP and say, I'm worried that my child has got a brain tumour, or if you're a teenager, that I've got a brain tumour because this and this, could you please refer me urgently? And we're trying to reduce the median time to diagnosis for patients with that. This is what's in the cards. It talks about preschool children vomiting, that should be poor balance, not pool balance, and walking problems, funny eye movements, lethargy, head growing quickly in babies whose soft spot hasn't closed, fits or seizures and funny head positions. For school-aged children, headache and vomiting becomes more important. Poor balance is obviously a difficulty. Funny eye movements and blurred vision, fits or seizures, lethargy or irritability, and funny head position. And again, the majority of children who have all these things will not have brain tumours. They will have something else, but they need to be investigated. And then for teenagers, headache and vomiting, funny eye movements, poor balance and coordination, and fits and seizures. And then another one, there are some tumours which actually damage the production of the normal hormones that you would have to go through puberty, and there are some teenagers who present to us who have clearly had a slowing down of growth when they should have had a speeding up in growth, and that should be something that you should think about it. The second thing, how are we going to improve care and services for children, is looking at organisation of services. And we want to look at, particularly there's been something called Safe and Sustainable Paediatric Surgical Services, which has hit the news very much recently because of issues with children's heart services. Similar things have been happening with children's neurosurgical services, and what we are trying to do is make sure that there is equity of access to children throughout England, because this is an English NHS thing. It should be the same throughout the UK, but we're trying to make sure there is equity of access so that everybody gets the same access to neurosurgeons, to paediatric oncologists, to neuropsychologists, and all the people that are necessary for the comprehensive care for children who've got brain tumours. When it comes to treatment, there's a number of questions that people may have. They may ask about choices. How can you help me? What's the right skills? How do I know I'm getting the best treatment? How does it compare to somewhere else? And how do I stop getting worse? In terms of treatment, there are 4 things that we can do. You can have observation, and as my colleague Steve Lewis in Bristol says, that could be known as MIHO, Masterly Inactivity Hawk-like Observation. Surgery to remove a tumour, chemotherapy, and radiotherapy. And this is that list of diagnoses that I showed to you earlier, and if you look across the row for each one, you'll find that apart from low-grade glioma, which has got sometimes with everything, you need to use mixes of these at different times. There are a number of clinical trials which are coming forward. At the moment, we actually find ourselves with no open clinical trial in the UK for children with brain tumours. The biggest one for low-grade glioma closed at the end of last year. There are 2 opening this year. One for medulloblastoma, which is looking at trying to reduce the amount of treatment we give to some selected groups of patients. And for other groups of standard risk patients to add in chemotherapy daily during their radiotherapy phase of treatment to see if we can actually reduce overall the amount of treatment that children get and increase the outcomes that we have for them. In terms of ependymoma, there is something called the COP Ependymoma 2 study, which is going to provide a European-wide comprehensive treatment strategy for all children from birth through to late teens, early 20s diagnosed with ependymoma. It's going to have a number of different arms and strategies of treatment there. With regard to radiotherapy, and I'm beginning to run out of time, so I'll skip through this fairly quickly, there is a question between should we be using conventional radiotherapy or should we be using proton beam radiotherapy. And the NHS has started to invest in using protons. And what are the pros and the cons? To take you through this very quickly, I'm going to have to stand up to the screen to show you this. If you fire a beam of X-rays or photons or a beam of protons through tissue, this is tissue here, depth in centimetres, this is the dose of radiation that you receive. With X-rays, they go all the way through. So if this was a tumour in the middle of your brain, this bit of normal brain would get X-rays if you gave X-rays, but with protons, because of something called the Bragg peep, where they deposit all their energy, you get all the energy is delivered there, and then there isn't an exit dose of radiation. So the bottom line is that for selected groups of patients, by using proton beam radiotherapy, you can reduce the amount of normal tissue that gets radiation, but they both do exactly the same thing to tumours. There are a number of patients who will have benefit from having this. There'll be others who won't. This slightly difficult to interpret slide here, if you look at blue, the bluer you are, the less radiation you've had. So if you're trying to treat the spinal cord, protons avoid the heart and the abdomen, the tissues in there. Highly complicated radiotherapy such as Mark would give can significantly reduce it. Conventional radiotherapy gives some dose there, which in public health terms is important, but it depends very much on the individual tumour that you're using, and I'll skip through that. Now, for my final slide then, there are important questions. How do I maintain normality? What should I look out for? When should I come back? And what should I do if treatment doesn't work? And so once someone has been diagnosed with a brain or spinal cord tumour, to be able to provide comprehensive care throughout the journey of treatment for cancer and beyond and into follow-up, we have the same requirements as you have for children who've got leukemia or other solid tumours. You need to be followed up to look for any effects of the disease, for any evidence of disease recurrence, for management if it does recur. You need to be followed up for the late effects of treatment, and that needs to comprehensively follow through into adult life. And the needs are no different to those of the other patients, but what you can say is that children with brain tumours, because of the important structures which are present within the head, which will inevitably have been damaged by, or almost inevitably have been damaged by disease or treatment, that the needs that those patients have will be greater than the others on average. So I'm going to stop the talk there. I believe that there's the opportunity for questions later on at the end. I'm very happy to take them then, or indeed individually afterwards if anyone has something for me. Thank you very much.